As you can see, the title of this talk is Point of Care Testing for Coagulopathy During Pregnancy. And for this talk, I have no relevant disclosures to declare. So what we're going to aim to do over the next 30 minutes or so is highlight some of the advantages about using point-of-care testing for detecting coagulopathy for pregnant patients. And then we're going to really hone in and discuss in some detail the characteristics of two key devices that we use for these assessments, which are thromboelastography, or TEG, and rotational thromboelastometry, which is Rotom. We'll discuss how and if and how these devices detect coagulopathy in various different settings which may occur for patients that have severe PPH. Just out of interest, show of hands, who has TEG at their hospital? There's a few of you, okay. And who has Rotom at their hospital? So that's not a bad turnout, okay. So let's start with a simple question first. Why should I bother thinking about these types of devices? I've got lab tests that are available, they can assess the coagulation profile, so what's the point? Why should I bother? Well, there are some potential advantages with using these devices. You're getting information that's come back to you over a very short period of time, which you can potentially get close to or at the patient's bedside if these devices are on the labour and delivery unit or close to it. The information you can get can often come back much sooner than you get with normal lab tests. And we certainly know that lab tests take a lot longer, and in many cases when we're doing transfusions, there's some data to suggest that nearly a third of transfusions occur in the absence of a transfusion trigger. In other words, you're not getting the lab data back soon enough to determine if you need to give products, and if you are, what type of products you're going to use. The other potential advantage of these devices is that they can supplement, and in an ideal world, maybe even replace, the lab data that you get that assesses the coagulation profile. These devices can be used to potentially detect problems with the coagulation profile, and then once you've detected that problem, depending upon what you use to manage the problem, you can then repeat the test to assess what the therapeutic effect is using the same point-of-care devices. So some people call these devices theranostic because they're used for diagnostic as well as therapeutic purposes. So let's briefly look at what we know about lab tests to determine how good they may or may not be for detecting problems with perioperative coagulopathic bleeding. And this is a summary of a fairly recent article that came out in the British Journal in 2015, published by a number of different experts with specific knowledge about coagulation changes during the perioperative setting. And what they did is they reviewed national and international guidelines from various hemostatic and transfusion societies that made recommendations about the transfusion trigger for using products if there was evidence of a change in the coagulation profile. And out of 11 society guidelines, 6 of these recommended that a transfusion trigger should be something close to or greater than 1.5-fold increase in the APTT or the PT. And yet the amazing thing is there's really a lack of high-quality evidence to substantiate the support of this trigger, with the overall conclusion of this article being that lab tests may actually be very poor at predicting coagulopathic bleeding. And this is from the last paragraph in the conclusion of the article, and the text here is very, very strong. The authors say that it seems questionable how long physicians are willing to use these tests for markers of coagulopathy or for guidance for bleeding management. But as always, old and even bad habits die hard. So that's a pretty damning indictment of the use of these tests for assessing coagulopathic perioperative bleeding. So are there any other alternative options? And these two devices are the ones that have probably attracted the greatest degree of interest. You have thromboelastography on the left, that's manufactured by Haemonetics Corporation, and you have rotational thromboelastometry, which is Rotom on the right-hand side, manufactured by TEM International, and this device now has a license for use in the US. Now we're seeing more and more societies are making reference to these devices in their guidelines. So the ASA made reference to both of these devices in the guidelines for perioperative blood management in 2015. Our European colleagues also did the same in their most recent set of guidelines. And the OAA, the obstetricians, the Obstetric Anaesthetists Association of the UK, also make reference to these devices in their anesthesia guidelines that came out in 2013. So let's talk a little bit about how these devices work. And here's a nice schematic that was published by Mike Gantner and colleagues back in 2008 in ANA. So we're going to spend a little time walking through this schematic for both these two devices. So let's look at TEG first, which is on the left. So what do? So you get a predetermined volume of blood, you place it in a vial called a cuvette labeled 1. The cup goes into a platform that you lift up, and then a needle attached to a torsion wire labeled 3 is inserted into the well of the cup. You push go on the machine, and the cup rotates around a very small angle of about 4.5 degrees. What happens after that is you get clot forming between the pin and the inner wall of the cup that puts torsion on the wire that's detected by a black box labeled 4. That signal is converted to an electrical signal, which then translates that signal to a trace depicted on your screen or computer screen labeled 5. Now with Rotom, you've got some similarities and also some subtle and important differences. You still place a predetermined volume of blood into a vial labeled 1, but instead of a pin being inserted into the vial, you have a rod which is labeled 3, which rotates. So the rod rotates, the cup stays still, but the rod rotates. When blood starts to form between the inner wall of the cup and the rod, that changes the torque of the rod. That's detected by a light emitting system labeled 4, and there's a light detection system that detects any change of torsion on the rod that's detected by a black box, which then converts that signal into an electrical signal labeled 5. Whoops. So what do the traces look like with TEG? So these are what the sort of normal looking trace looks like with both TEG and also, with Rotom. There are a number of parameters that you can use for each of these devices that give you specific information about the viscoelastic properties of clot formation and clot lysis. So if you look at the top half of this diagram, we look at the black half, that's TEG. You can get 4 main parameters that look at clot formation, which are the R, or reaction time, that gives you information about the initiation of clot formation, the K time, that gives you some idea about clot strength, the alpha angle, which gives you information about the degree of fibrin polymerization, and the maximum amplitude, or MA, that gives you information about overall clot strength, which is likely to be influenced by fibrin platelet binding. Now with Rotom, the nomenclature for the parameters are somewhat different. Instead of reaction time, you have CT, or clotting time. Instead of K time, you have CFT, which is clot formation time. The alpha angle nomenclature is the same, but instead of MA, you have maximum clot firmness. Now the thing to note is that even though they're measuring very similar properties of the trace, the reference ranges for each of these parameters on TEG are different from those with Rotom. So in other words, you're not going to have the same reference ranges, and also the value itself may be different if you compare TEG with Rotom. So don't assume that the MA with TEG will be exactly the same as the maximum clot firmness value if you look at the same sample from the same patient with Rotom. So let's look in a little more detail about what normal traces look like with each of these 2 devices. So with Rotom, it's a 4-channel device, so you get 4 traces. These are XTEM, looking at the extrinsic pathway, INTEM, looking at the intrinsic pathway, FibTEM, which looks at the fibrinogen contribution to clot formation, and then ABTEM, which gives you information about whether there's problems with excessive clot lysis or hyperfibrinolysis. So with each of these traces, you can gauge whether there's any issues that may be related to any component related to clot formation and potentially clot lysis. The other thing to note here is you can get information about clot strength, which is not just from maximum clot firmness. You can measure the amplitude at either 5 minutes or 10 minutes with Rotom, and this information is consistent with the clot strength as if you were to measure it with the maximum clot firmness, which comes in much later. So that's really important, because at 5 minutes you can get a lot of information that may help you to determine if there's a problem with the coagulation profile, and if it is, what type of problem is going on. Now this is a normal TEG profile. The nice thing with TEG is that you're getting reference ranges with the actual values for each of these parameters you can see below the actual trace. But the only thing to note with TEG is it's a mono-channel device, so you won't get FibTEM, you won't get XTEM, you'll only get 1 trace appearing with each channel on the TEG machine, and it's a 2-channel device. So what do the traces look like in a pregnant patient who's otherwise healthy and normal compared to a non-pregnant comparator? So here's an example. This is data from Hussein and colleagues that did this exact thing, where they compared traces from a normal pregnant patient to someone who wasn't pregnant. And the top 2 traces are from a non-pregnant control, from XTEM and FibTEM, and the bottom 2 traces are from a pregnant patient. So you can see the top 2 traces look different from the bottom 2 traces. The bottom 2 traces look like they're somewhat fatter looking than the top 2 traces, and also the clot seems to start a lot sooner, and the alpha angles seem to be a lot greater. So in other words, what we're seeing here is evidence with Rotem that is consistent with the hypercoagulable state associated with pregnancy. So greater degree of clot strength, greater degree of clot initiation, and a greater degree of fibrin polymerization as well. All right, so with that in mind, what sorts of traces would we see if there's problems with abnormal coagulation with both TEG and Rotem? Well, before we get into the weeds of it, one of the nice things that you can get from the literature and also from the manufacturers are algorithms and decision trees to help you determine what these problems are and how you can treat accordingly. So this is quite a nice algorithm which has been produced by Haemonetics. So you look over to the left-hand side, it walks you through what to do once you get a trace back if there's a problem with individual TEG parameters, be it a prolonged R time, a decreased maximum amplitude, a decreased alpha, or any problems that may affect clot lysis, which we'll discuss later on. Rotom also have good information available on their website, but also there's also some excellent information available from the Australians. And I'd like to thank Kim Osborne, who's here from Adelaide. Give us a wave, Kim. I think you're out there somewhere. Who made reference to this excellent website that's been produced by the King Edward Memorial Hospital in Perth, who really go into a lot of detail about how Rotem works, and they give you excellent examples about what abnormal traces look like for individual problems associated with a coagulation profile related to pregnancy. So I'd encourage you to take a photo of this if you use Rotem at your hospital and take a good look at this website. It really is really, really good. So they also have an algorithm as well, which they use at their hospital, which they make available on their website. And the nice thing is they're showing you what the parameters look like when they're abnormal, and also give you information about what the traces look like if there's a decrease in the fibrinogen, a decrease in the platelets count, if there's excessive clot lysis, or if there's a decrease in clotting factors. And don't worry, we'll look at this in a little more detail shortly. And the other nice thing that they do is they give you information about how to treat or intervene depending upon if there's a problem with an individual parameter with Rotem. So let's look at fibrinogen deficiency first. And the reason why is that there's a lot of interest about this in obstetrics right now. And I don't want to overlap too much with what you're going to hear from John Markley later on, but I'm going to just touch upon this just for a little bit. There is some there's actually good data from observational studies that showed that if you measure the fibrinogen level during the early phase of bleeding after delivery, and the level is found to be relatively low, and low meaning not less than 100, but less than 200 or even less than 250, that's a very strong risk factor for the patient going on to develop severe postpartum hemorrhage. So one of the things that I would encourage you to do, even if you don't have these devices, and if you're worried about a patient starting to bleed, is send off even standard labs early, including a fibrinogen count, and repeat it, because if the fibrinogen count is found to be less than 250 or certainly less than 200, that's a red flag, and you should be preparing yourself accordingly for further problems with bleeding. So what do the Rotem traces look like for a patient that has fibrinogen deficiency? So what I've done here is I've got a normal looking Rotem traces on the left and traces that are associated with fibrin deficiency on the right-hand side with Rotem. So what you're seeing here is you're seeing a decrease in the amplitudes, the A10 and the MCF, with both XTEM and also with FibTEM. So this is giving you information to indicate that there's a decrease in the contribution of fibrin or fibrinogen to clot formation. If you look at the FibTEM profiles, you look at the XTEM profiles, even from a distance, you can see that they are skinnier looking than the ones on the left-hand side. Now, the Australians give some parameters here to help guide you. So, in other words, if you measure the amplitude at 5 minutes with the FibTEM profile, and it's equal to or less than 10 millimeters, that may well be indicative of the patient having a low fibrinogen count, and then you may need to think about a way to supplement this with either Rheostat, fibrinogen concentrate, or with cryoprecipitate. Now, do we know if these values compare well to a plasma fibrinogen value if you measure it during the early phase of bleeding? And the answer seems to be yes. This is an excellent study that came out from the Collins group in the UK, where they measured the FibTEM A5, so the amplitude at 5 minutes with FibTEM, and they measured the fibrinogen level at the same time. And both values were equally good at predicting the need for either 4 or more units of red cells or 8 or more units of blood products for patients that had severe postpartum hemorrhage. So the take home here is that you're getting information back much sooner with Rotom, because you're getting that information back at 5 minutes, then you might do, if you measure the fibrinogen level, which with the best one in the world can take 20 minutes, 30 minutes, 40 minutes, and in some places a bit longer. So what does a decrease in fibrinogen, what does a decrease in the fibrinogen level look like with TEG? So I've done the same thing here as I did with Rotom. You've got a normal looking TEG trace on the left-hand side, and you've got a trace that looks like you've got fibrinogen deficiency on the right-hand side. So what you're seeing here is a decrease in the alpha angle. So you can see here it's less than 45 degrees. So that's probably consistent with a patient that has a decrease in their fibrinogen level. There's also some suggestion on this trace that maybe the Rotom is looking like it's a little long. So what do you do in this case? Well, it might be a case where you want to replace with fibrinogen first and then repeat to see whether the reaction time is still prolonged or not accordingly. Now, a thing to note with TEG is that they don't have a FibTem equivalent that comes out with a native sample. So if you want to look for the fibrinogen contribution specifically to clot formation, you have to run another test called a functional fibrinogen test. So now you can differentiate if there's a decrease in the MA, whether it's due to fibrinogen or whether it's due to a platelet count or platelet function problem. How does it do this? Well, you run a sample in a separate channel where you're adding in a platelet inhibitor, and then you're measuring the maximum amplitude again to determine whether, if it's reduced, it's due to a decrease in fibrinogen. Now, the data on this is only just coming out in terms of validation, and there's a few studies that are appearing suggesting that the functional fibrinogen level you measure with TEG may slightly overestimate the fibrinogen level, but nonetheless, it might be helpful to use as a guide if you have it available to you in your hospital. Okay, so what about if we have a problem with a decrease in platelet function or a decrease in platelet number? What sort of traces do we get with Rotom? So same thing as we did before, normal looking trace on the left-hand side and decrease in platelet function or number on the right-hand side. In this case, we can see that the amplitudes with XTEM are reduced. So we see a decrease in the A10 value and we see a decrease in the MCF value. But if you look at FibTem, you can see that the amplitudes with FibTem are not decreased. So it looks like in this case, it's only affecting the XTEM profile, suggesting this is probably only a platelet problem, but not a fibrinogen problem. And if anything, the trace with FibTem on the right-hand side looks a little fatter than it does on the left-hand side, suggesting that physiologically there may be some compensation with what's going on with an increase in the fibrinogen level or concentration. Now, if you look at the Australian sort of algorithm, they would suggest if there's a decrease in platelet function or number, use these criteria. So an XTEM A5 that's equal to or less than 35 millimeters and a FibTem that's not reduced. So an A5 FibTem value that's equal to or more than 10 millimeters. What about with TEG? So we have a normal trace on the left-hand side. This is a trace which we think is consistent with a decrease in platelet count or function on the right-hand side. In this case, we can see the MA, the maximum amplitude, is decreased. The R time looks okay. The alpha angle also actually seems to be a little bit low. But in this case, what you might want to do is treat with platelets. Again, repeat the test to determine if the alpha angle is still reduced. And if it is, then maybe you want to treat with fibrinogen. So the point here is that you need to react to a problem and then test again to see if the trace is improving or not, as the case may be. What about a trace that has that is suggestive of a clotting factor deficiency? So this is where it gets a little trickier, because certainly in obstetrics we tend not to see, certainly in the setting of PPH, problems where you're only seeing an isolated clotting factor deficiency. Often it's the case where we're seeing multiple problems with the coagulation profile, certainly in the very severe cases of PPH, that impact not just a decrease in clotting factors, but a decrease in fibrinogen and potentially a decrease in platelet counts as well. So it was actually quite hard for me to find a profile from a TEG trace that only looked at a decrease in clotting factors. But notably, what you can see here is that the R time is very long, so it's well over 10 minutes. You can see here that the MA looks like it's on the lower limit of normal, and the alpha angle is also low. So it might be the case that the decrease in the clotting factors is impacting the quality of fiber and platelet binding. So what you might want to do in this case is give plasma, repeat again, see if that improves the alpha angle, but if it doesn't, then consider using fibrinogen supplementation. So I had a similar problem finding a trace with Rotom that showed an isolated decrease in clotting factor deficiency. So here again we're seeing an example of a patient that has severe hemorrhage that is impacting on a number of different parts of the Rotom trace. So this is XTEM. You can see here that the clotting time is very long. The clot formation time also very increased. The A10 value is down, so the amplitude is decreased. So this is not a good looking trace. What about the FibTem profile? Also ugly looking. It's super skinny and super thin, suggesting that we have a problem here that's maybe impacted by a decrease in clotting factors, a decrease in platelet count, and also potentially a decrease in the fibrinogen level as well. So this patient needs a lot of hematological support. And lastly, hyperfibrinolysis. So later on in this panel, in fact, next up is going to be John, who's going to be talking about the use of an antifibrinolytic for managing patients with PPH. But what you might be interested to know is there evidence to show there's an indication for the use of an antifibrinolytic? Can we show, at least from a coagulation standpoint, that someone may have hyperfibrinolysis? So the answer seems to be yes. With TEG, you get this sort of image if you have a patient that has hyperfibrinolysis. So this is what we call a teardrop-looking trace, or what I sometimes describe as a snake that swallowed a Foley bulb. So when you see a trace like this is a major red flag. You want to get lots and lots of help if the patient is having a massive PPH. Here we've got a lot of we have a lot of breakdown occurring very early and to a very large degree. So this patient certainly should have an antifibrinolytic as part of their hemorrhage resuscitation support. A similar looking trace can be seen also with Rotom. Certainly if you look at the XTEM profile, you can see that teardrop looking formation on the XTEM profile, but also look at Abtem. Remember, Abtem is the trace where you're adding in an antifibrinolytic to see whether it reverses any presence of excessive clot lysis, and indeed it does. The Abtem profile looks like it's pretty normal, which provides further support that there's problems with hyperfibrinolysis. So again, with this type of trace, this is a patient who, in addition to normal coagulation support, certainly should get an antifibrinolytic. So this is all well and good, but you may be wondering to yourself, okay, great, Alex, this is nice, you have lovely traces, and you're showing me individual problems with the coagulation profile, but so what? How much do we know about whether point-of-care guided treatment actually improves outcomes, or maybe whether it reduces the need for transfusion support? And this is where the evidence is somewhat more limited. There was a good systematic review that came out in Anesthesia last year, where they made an attempt to look at studies comparing outcomes in patients that were resuscitated with point-of-care devices versus standard of care. And there was a suggestion that mortality was reduced in those patients that received Rotom or TEG guided care as part of their hemostatic treatment. But unfortunately, the studies were relatively small in number, the sizes were fairly small, and there was a reasonable amount of heterogeneity. They also looked to see whether there was any difference in the amount of blood product that was used. And there was a suggestion also that patients that were treated with TEG or Rotom also were less likely to require product support in the form of red cells, plasma, or platelets. But for some of these products, or some of these point estimates, you can see that the confidence intervals are relatively wide. So what about in OB? Do we have any data in the OB or the OB anesthesia literature to suggest that these devices can be quite helpful? So there isn't an awful lot out there. Most of the studies that have looked at this are retrospective, but this is probably the best one that came out from the UK by Malia and colleagues. This is quite an interesting article where they had a massive transfusion protocol specific to obstetrics, and then they modified it after its introduction to incorporate fibrinogen concentrate as well as point of care with Rotom. And then what they did is they assessed whether there was a difference in the number of products that were being used before they changed their protocol to afterwards. And as you can see here on the slide, after changing their protocol, there was a decrease in the total number of products that were used, a decrease in the amount of plasma, cryoprecipitate, and a trend towards a decrease in the number of units of red cells as well. And there's been a few other articles that also provide some lower level evidence to suggest that the use of these devices may be quite helpful for patients with very specific coagulation problems, such as abruptions, which are the ones that really worry me. And also some data very recently published in the Journal of Clinical Anesthesia that also supports the data that came out from Malia indicating that there may be a trend towards a decrease in the amount of products that are being used. Now, obviously, I'm trying to paint a rosy picture here, so I've got to be balanced in the way that I'm discussing these devices, and there are some potential things to think about which may be downsides. So obviously these devices incur some costs, not just in terms of the device, but the peripherals and the ancillary supplies that you need for maintenance and calibration. These devices have required daily calibration, in fact. So we need to figure out where that's going to be done and who's going to be doing it. And obviously the other thing to think about is, unfortunately, in terms of our education and training, we certainly don't get a lot of information or training about these types of devices, either in our nursing or medical schools, either during residency or during our nursing training, or maybe even after training. So certainly when I see residents at Stanford, unfortunately many of them don't get exposure to the information that you can get from these types of devices, or even how to interpret them. And then there's a couple of logistical issues. Where should we house these devices? Should we have them on the labor and delivery units so they're close to us? That limits the time between getting the blood and running the samples. But obviously if you have them, someone's got to do it, and therefore that may take that person out of the equation if you need them for resuscitation. So is a hematology lab a better place for these devices? If it is, remember that it takes a bit longer for the sample to get down to the lab, but at the same time someone else is running the samples, and if you're lucky, the machines, the instruments that they use to run the samples can be connected to your electronic health record, so you can still see the trace form real time on your Epic view, but it means that you're out of the loop. You don't have to worry about running the samples yourself. So there's definitely some pluses and minuses depending upon where you choose to site these devices. And there's also a couple of don't knows. And what are the don't knows? We still don't know whether outcomes, maternal outcomes or transfusion utilization differs depending upon if we're using goal-directed therapy with either TEG or Rotom versus fixed ratio versus maybe a hybrid approach where you may start using fixed ratio and then move to goal-directed therapy later on. We don't know whether outcomes or, in terms of cost-benefit, whether cost-effectiveness is better if you used either TEG or Rotom compared to goal-directed therapy using standard lab tests, or whether outcomes are different depending on if you use standard labs versus standard labs supplemented by information from these point-of-care devices. And the last thing we don't know is whether the information from TEG gives you better quality information for improving outcomes or not versus Rotom. So these are the sort of things that investigators need to think about in future years. So the other thing to bear in mind is that obviously technology is changing, and the companies realize this, and they are the latest form of these devices that are being released are the ones that you can see here on this slide. We have the TEG 6S on the left, and we have Rotom Sigma on the right. So what is different about these devices compared to the parent devices? Well, the nice thing with these devices, at least from a systems or a logistical standpoint, is you have cartridges now that you can use in a similar fashion that you use, say, if you've got a HemoQ. So you put the blood sample in the cartridge, and you push the cartridge into the opening that you can see here on each of these two devices. And the rest of it is automated. So now there's no more problems with manual pipetting. It's a much more automated process, which is much more time efficient. So the concepts now look really cool, but what we really want to know is whether the information from these devices is consistent with the information you get from the parent's devices. So we need to get more validation studies under our belt to confirm to us the information that we get is consistent with the early devices, and if it is, then show that maybe we can do something with it. So hopefully I've made an attempt to try and convince you, if you don't already feel that way, that these devices can potentially be useful. And if you have any more questions, then I'll be happy to address them in the session, or you can tweet me, Facebook me, email me. Thank you very much.